Today's topic is Stemi management, who are presenting late, somewhere between 24 to 48 hours. What is late? By definition, traditional definition, symptom duration more than 12 hours is late presenter. And if you look at the data, if you look at multiple registries, worldwide late presenter for acute MI or ST elevation MI is nearly 8.5 to 40%, and in India it is more than 30%. This is a registry. But in real world, this number may be much more higher than this.
Yeah, one caveat I asked. The patient having chest pain on day 1 for 10 to 15 minutes. Somehow he neglects that chest pain and he doesn't. And no ECG is taken, no troponin is done. The second day again he develops chest pain. And now he presents to you. So how will you again these symptoms more than 24 hours?
More than 24 hours. Actually more than 24 hours. But generally what happens, if it is ST elevation MI, pain does not subside as such. If it is non-ST elevation MI,
there are patients with diabetic
patients are
even I have seen patients, non-diabetic patient who had gone on a tour and
points like that, the points are there, but there are no exact definition that from when you should count 12 hours. But in general, first chest pain, you count 12 hours from first chest pain.
Will the ECG, done as he says, after 24 hours or 12 or 18 hours, will it show an indication?
It shows there.
Whether it was yesterday, take off or it has taken off today?
Yeah, it is there. It is there.
That is it.
To a certain extent, it will help.
So most of the time what happens, the patient who had pain, they subdued all her activity and stays rest. Most of the time, he starts feeling relatively better. But once he goes into routine activity and then pain recurs or he feels pain again, then he comes to hospital.
So same thing happens for unstable angina also, or even stable angina also. Patient is developing pain on exertion, they will stop exertion, they will stop walking, they will reduce walking to maybe 2 kilometers, and then they will not get any pain. So this is same thing which is true for this case also. So why 12 hours is a limit? Because trials, traditional trial did show there was no mortality benefit and there is increased risk of intracerebral hemorrhage by fibrinolysis beyond 12 hours. That's why this 12-hour limit was set. Late presenter were not included in the trial showing superiority of primary PCR over 5 minutes. So this was old trials, and that's why this was traditional teaching that 12 hours is an arbitrary limit. Why do patients present late? Most of the things we have already discussed, because patients are unaware or in denial. Majority of Indian patients are in denial and they have lack of education. They have atypical chest pain, particularly diabetic patients or females, or they have no chest pain at all sometimes, or there is stuttering chest pain like unstable angina, 2 and Stemi, 2 ST elevation. What sir has said, there is stuttering chest pain, pain today, relieved, again pain next day, then patient will develop Stemi on next day. Then there is sometimes heart failure. This patients are treated on respiratory medicines and ST elevation MI is already missed. Refusal to seek medical attention or refusal to go for alternative medicines.
Yes.
Then geography and socioeconomic status is also a problem in our country. Sometimes it is wrongly diagnosed, atypical presentations or patient presenting to non-PCR hospitals. That can also delay the thing. So let's come to real world scenario. This is a real patient. He was a 54-year male. He had chest pain on and off, NYHA grade 1 dyspnea. Past history of hypertension and diabetes mellitus was there, and there was no significant family history. This was his dyspnea, and chest pain was of 7 days duration. So, Haji, you would like to describe this?
This is a 12-lead ECG, normal sinus, during ST elevation in V2, V3, V4, V5, this is and 1 area, reciprocal scan in film. This is a acute extensive order.
Anything about 1 AVL? 1 AVL also has experience. AVR has
This is
experience.
a Q from proximal area. Q wave also. This is late presentation, more than 70 minutes.
Proximal LAD central after surgery.
This should be very early.
After
Very
After
much.
V1 is
Yeah. So V1 is not showing elevation. So septal is part. The lateral leads are showing elevation. So it is diagonal is involved. So it is somewhere between septal and diagonal. Sometimes things may show the other way on angiogram. But ECG wise, yes. Any comments on the next elevation or QRS pattern?
PV.
So there is already deep QOS has been developed in V2.
QS is level.
Lead 1 in lead AVL, lead 1. So this is Q wave elevation MI. In general, Q wave develops when the infarct has already started. But there is persistent elevation even at the end of 7 days. So how ECG helps us? Now, there is correlation with ECG and infarct related artery. In early latecomers, that is somewhere between 12 to 24 hours or 12 to 48 hours, the negative T wave suggests marker of reperfusion. It should be strongly considered. If patient is negative T wave, patient must have autolyzed or patient must have been thrombolized or maybe artery has opened up, thrombosis passed up, and there is reperfusion is already developed. Positive T wave, there is high probability of occluded infarct related artery still, like in our case. The T waves are still positive.
Or a spasm.
Yeah, spasm also. Yes, spasm also. So T waves are here still positive. So this is still an infarcted or occluded infarct related artery. After successful treatment of Stemi, normalization of ST segment occurs accompanied with T wave inversion. Here in this case, STs are still elevated. J point is still elevated. So the reperfusion is not yet completed. So by now we know that this patient has still occluded artery. Should we intervene for that or not? But if you look at the Dani study, demonstrated that patency of infarct related artery is major determinant of salvage of large amount of myocardium by PCI. The Danish trial told us that this patient should undergo PCI independent of time. This is old trial. And on the contrary, timing plays a major role when IRA is totally occluded. According to the paradigm, earlier is better. So there are controversial opinions. One trial did told us that if there is infarct related artery, large amount of myocardium is at risk, open it. Other trial told is earlier the better, late. That will come in sequence. So traditional teaching by now is all patients presenting within 12 hours of time should be considered.
Ronak, it is a major determinant of the salvage of large amount of myocardium. So they have checked with any perfusion study or plus occluded state?
No, that time in perfusion studies were not
Nothing.
checked. This is very good.
Yes. Okay.
Perfusion also has come on.
Outside, right?
So this is the case sequence where we will go. We hope
Yeah, of
this
course.
is as of now. So patient presenting within 12 hours of Stemi should be considered for reperfusion strategy. That is for sure. There are no doubt about it. Reperfusion not routinely recommended who present more than 12 hours after Stemi. But if you look at this chart, this light gray area is a critical time dependent period where myocardial reperfusion has to be done. That is initial 2 hours. Nobody presents within initial 2 hours. Up to 12 hours, there is time independent goal is to open infarct related artery. Beyond 12 to 24 hours, there are guidelines are controversial. And beyond 24 hours, it is absolutely controversial. But tradition needs to be changed. Why? If we look at this registry received reperfusion and the number of major adverse cardiac events that includes death, myocardial reinfarction or recurrent angina is 11%. People who did not receive reperfusion in T-TEMI trial, 16.5% was the MACE rate. In the registry also, 19.1% MACE rate. So the adverse events or cardiac events are much more higher when patient did not receive any.
Are these data statistically comparable to age, comorbidities, first
Yes,
episodes?
yes.
They are all comparable.
Age, comorbidities, gender, it is
These
comparable.
are very old data, and at times
These are also old data.
current treatment.
These are also old data. These are also.
So this
These
is
are
our
data somewhere in 2000 and not even 2000, before 2000.
19% would be a patient who had too many other complications.
Yes.
11% would be a non-diabetic youngster. So,
And problem is that this registry did not include patient with hypertension, did not include patient with congestive heart failure or cardiogenic shock. Stemi do had patients with cardiogenic shock, but not with congestive heart failure.
So this is a sort of a small meta-analysis of few study. Propensity matching नहीं करी हुआ है और बहुत heterogeneity है से.
Registry is meta-analysis, so registry is registry actually.
Yeah, so
That cannot be
आपने जो
controlled.
reperfusion is must છે ત્યારની understanding બતાવો છો કે તમે કયો છો?
ના, હજુ
ત્યારની understanding
Yeah.
બતાવો છો, right? Okay, કારણ કે આના ઉપર તો કશું ના કહેવાય.
Yeah. So reperfusion should be done based on primarily this data. So let's see how tradition is changed based on scientific evidence. So this is our patient underwent echo. Echo did show the septal. The thickness is still preserved. There are some bright areas, so there is some scar has already been started. Even here, the subendocardium did show bright echo texture. So there is some scar has already been started in subendocardium. Anterior wall is severely hypokinetic, but it is not yet thinned out. Even here also, the septum looks preserved. So how echo will help us? In general, thickness of ventricular wall, if there is preserved thickness, there will be benefit from opening the artery. Wall motion abnormality, if there is akinesia at all, or thinning of the wall, then we require viability testing in terms of cardiac MRI or in terms of SPECT or systemic scan or nuclear scan. And LV ejection fraction less than 40%. All trial need so that it will increase mortality, whether you are going for reperfusion or not. So LVF is one parameter that will help us, and other parameter that will help us is wall thickness and
So
upright.
this comment is pertaining to within 7 days of presentation or
Any
how
day,
many days?
any day,
Any duration.
any day. Even in patients with triple vessel disease, generally surgeon prefers to get done a myocardial viability when ejection fraction is less than 40%. So they can offer better.
So I guess Priyank probably few months they presented a study here. It was viability study beyond 2 months or something like that, right?
Yes.
So almost similar type of situation.
Yes, yes. So beyond 24 hours or beyond 12 hours, if thickness is not preserved, there is akinesia, then definitely nuclear scans or viability scans will help us. Even if we are planning for this coronary intervention or angioplasty also, it should be done. Now there are some logistic problems also. The cost issue is there, Ayushman card is there, so that
Yeah, we
cannot
are
be
not
done in
doing
all
that's a
cases.
separate issue, but it is indicated.
Yeah, that cannot be done in all cases. But echo can help. If even beyond 7 days, thickness is preserved. It means there are two things. It means the LAD which has been occluded from proximal segment, maybe it is getting retrograde flow from RC or LCX or somewhere else. That's why thickness is still preserved and myocardium is viable. Or there may be some intracoronary collateral has been developed. Or there is some trickle of flow which is going antegradly in the LAD also. So there are 3-4 possibilities why thickness is preserved. So this patient who have viable myocardium will get benefit from intervention at any point of time, beyond 48 hours also. So by far our patient had delayed presentation. He had ongoing chest pain which suggests ongoing ischemia or ongoing myocardial damage. There were borderline hemodynamics, persistent ST segment elevation with upright T wave in ECG which suggests totally occluded artery, LAD, and hypokinetic anterior wall but with preserved thickness. So what should be the next step? Let's again go back to studies. In clinical practice, proportion of late presenter that we already discussed. So there is a hypothesis called open artery hypothesis. So everything evolves around or moves around this open artery hypothesis. Open artery hypothesis proposed that late reperfusion beyond window for myocardial salvage also reduces LV remodeling and it decreases mortality. So this was the fundamental of open artery hypothesis. It reduces LV remodeling, it reduces LV dilatation and it reduces mortality, it reduces arrhythmia also. Experimental and observational data suggests that late achieving reperfusion may confer benefits that are necrosis independent and partially time independent. And infarct-related artery opening may be beneficial by preventing LV dilatation. It improves survival by limiting infarct size and associated deterioration of LV function. It also prevents adverse LV remodeling. It also maintains electrical stability so that patient will not die of arrhythmia. And it also helps to regenerate collaterals to remaining while on heart. So these are 3 points why we should open that artery. That's what's told us by open artery hypothesis. What trial told us?
So what are the hypotheses about disadvantages of opening late?
Disadvantages are also there.
So,
Because in trials, this was hypothesis. When this hypothesis was subjected to trials, there are few trials which did not show any benefit. Few trials did show adverse effect in terms of LV dilatation, which was hypothesis did told us that LV dilatation will be less. There will be positive remodeling. But trial did show that there is opposite. So LV dilatation was more when it was done beyond 7 days. Yes, that is also possible. But VSR is not very frequent.
that's okay, but if we are enumerating advantages and disadvantages can be discussed.
So this is the first trial, which was occluded artery trial, OAT trial in 2002-2003. The PCI with stenting performed 3 days to 6 weeks after anterior MI. There was greater LV dilatation with late birth. First trial they told us that the hypothesis 1 point, there will be LV remodeling. That was not very true. There was 44% increase in adverse event risk. But late reperfusion improved exercise tolerance. It improved quality of life. That was the only advantage which was shown in this trial. The major problem with this trial was the median time to revascularization was very long. It was 8 days post Stemi. And it was too late for benefit. Maybe earlier is still better. So maybe up to 7 days is better. Cardiac mortality gradually increased as LVEF decreased below 40%. OAT population only 21% and LVEF less than 40%. So this trial is not very fruitful.
The range from 3 days to 6 weeks is
It's long.
too wide to comment at all on this trial actually.
Too wide. This was the first trial. So next few trials will come. But still, it did show improved quality of life and effort in terms. The long-term result, there were no mortality benefit by PCI versus OLT. But angina significantly less at the end of 7 weeks. And repeat revascularization was significantly less at the end of 7 weeks. So these are some minor benefits. There was improved quality of life, angina was less, there was less amount of re-intervention or repeat revascularization. Based on
There
this,
is little doubtful because this all must be the bare metal stents, right?
yes, it's 2002. Yes. And PCI, that was PCI, which is 7-year data. We have to go 7 years back in from 2002. So maybe some cases had also this balloon angioplasty also. Then comes another trial in 2004-5, DCOPY trial, which also included MI randomized 2 to 15 days after myocardial infarction to PCR, no PCR. Improved LVEF with reperfusion was shown in this trial. There was no difference in clinical outcome at 6 months. And infarct-related artery patency showed markedly improved clinical outcome, which suggests prevention of restenosis and reocclusion is a key to clinical benefit. So this was the first positive trial. But again, day was 2 to 15 days post-MI. Then there are multiple trials. TOPOL trial, TOT trial, DCOPY, DCOPY 2, TOSCA 2, OAT, and there were mixed response. The red mark were negative trial for interventions, the green mark were positive trial for interventions. Mixed response at all. In 2005, a major trial was released, published, that was BRAVE 2, which showed that 365 Stemi patient 12 to 48 hours after onset without persistent symptoms. So this was the first trial where the time limit was set between 12 to 48 hours. It excluded patients in failure class 3 and 4. So heart failure were excluded, hypotension excluded, cardiogenic shock excluded. And it was randomized to PCI versus medical management. First endpoint, which was supposed to be, was LV infarct size at 10 days by SPECT, and second endpoint was death, MI or stroke at 30 days. Results were LV infarct size in PCI was 8%, versus 13% LV infarct in medical management. So LV infarct size has been reduced by PCI between 12 to 48 hours. No significant difference in clinical endpoint, but favorable 33% relative risk reduction at 30 days, although it was not statistically significant. Better initial TIMI grade or patency of IRA was significant predictor. That's what we discussed, that T inversion suggests there is reperfusion already has occurred. So that has shown a better result. Initial TIMI grade. TIMI grade is basically blood flow in the artery. There is TIMI 3, blood flow is normal. TIMI 2 is less than normal. TIMI 1 is less, even lesser.
33% relative risk of what?
Relative risk reduction of this primary endpoint, secondary endpoints, death, MI or stroke at 30 days. Long-term result, long-term follow-up, 4-year mortality was reduced by 45%. So, based on this trial, we can say that if patient present was within 12 to 48 hours, PCI should help in our favorable terms. But again, this trial has excluded many patients.
See, the purpose of doing a plastic is to take care of the other three things. Hypertension, say, get the patient out of shock.
So there is no doubt, if patient is in cardiogenic shock or heart failure, PCI has to be done.
It's like driving back only if there is a spinner. I will not back if there is fast loader.
So infarct size and myocardial salvage after primary angioplasty in patients presenting symptoms for less than 12 hours, like 12 to 17 hours. This was another trial which was published in 2009, which showed that LV infarct size was larger in late presenter as expected, but percentage area salvaged by PCI was 53% in late presenter versus 66% in early presenters. And what we are discussing about PCI versus medical management, salvaged area 44% even in occluded artery. So even with patient with occluded infarct related artery, 44% area can be salvaged versus patient during PCI has little bit flow in artery. So even totally occluded, if you do PCI, 44% area can be salvaged. Meta-analysis published in 2009, 3,560 patients randomized to PCI versus OMT. Late PCI improved survival as compared with medical treatment. All-cause mortality was reduced, which shows favorable effect on cardiac function and remodeling. Improvement of plus 4.4% of LVEF. Long-term positive influence of PCI by preventing apoptosis of hibernating myocardium. So this is also another topic, stunned myocardium versus hibernating myocardium. This is also very vast topic, cannot be covered here. Mortality reduction in this meta-analysis published in 2009. So this was trial, what we have discussed till now, OAT, DCOB, BRAVE 2, everything was included. There was mortality benefit for patients presenting late. MACE rate reduction in terms of death or myocardial infarction, death, non-fatal reinfarction, re-hospitalization, everything was favorable. Even here also, change in ejection fraction from baseline to follow-up, it is also favors PCI. Change in end diastolic volume favors PCI. Change in end systolic volume favors PCI. So this trial, this meta-analysis was the only thing which told us that late presenter should undergo PCI. What guidelines is? The guidelines will also change. 2007, before meta-analysis. ACCH had told us PCI for latecomers. Class 1 or 2 A indication only if there is reinfarction. Evidence of spontaneous or inducible ischemia, maybe based on treadmill days, maybe based on SPECT scan or whatever. Cardiogenic shock or hemodynamic instability. Evidence of LVEF less than 40%. Heart failure or serious ventricular arrhythmias. For PCI in stable patients presenting more than 24 hours without evidence of ischemia, PCI is not required. It is class 3 in 2007.
This, they have not mentioned ongoing ischemia. ESC they have mentioned.
Yeah, they have mentioned that inducible ischemia. Not ongoing, but
Not
inducible
ongoing.
ischemia, yes. Reinfarction means yes, ongoing ischemia. And PCI that time is stable patients without any ongoing ischemia. It is class 3. ESC 2008, Stemi with more than 12 hours duration. Clinical and electrocardiographic evidence of ongoing ischemia. It is class 2A indication. Stable patients Stemi class 2B indication. So Europeans were more in favor of PCI, even at that time. 2013, evidence of ongoing ischemia, 12 to 24 hours symptom onset, class 2. PCR non-infarct-related artery class 3, that is not of importance. But 12 to 24 hours has come to class 2A. 2014 ESC guidelines, reperfusion therapy with primary PCI should be considered in patient presenting late, that is 12 to 48 hours after symptom onset. Class 2 indication, even if stable, everything was removed, all other criteria were removed. In patient with time from symptom onset more than 12 hours, PCI is indicated in presence of continuing ischemia, life-threatening arrhythmia or pain and ECG changes. So if this is there, it is class 1. If patient is stable, class 2.
Diabetic patient, there is no angina.
There is no angina. So you don't know. Yeah, so you don't know the
Diabetic complete heart failure.
Yes. So you have to rely on ECG, echo, maybe stress testing if possible, or maybe viability testing. In patient with time from symptoms and more than 12 hours, primary PCI is indicated in the presence of ongoing symptom signs that we have discussed, that is class 1, 12 to 24 hours. Routine PCI strategy should be considered class 2A. So routine PCI without any symptoms. But there are no simple and specific guidelines to manage patients when they present late. So 12 hours is an arbitrary limit. Myocardial salvage is still possible. Like if you look at this chart, this green one is patient undergoing PCI and blue one is patient undergoing thrombolysis. And this is the myocardial salvage and this is salvage index. Even beyond 12 hours, when thrombolysis is contraindicated, opening artery by PCI improves myocardial salvage and myocardial salvageability index. So beyond 12 hours also, PCI will help. How we can further stratify these patients? By now we are in ECG and echo. So further risk stratification can be done with stress testing. May it be a treadmill test or may it be a stress test. For assessing exercise capacity, identifying persistent ischemia and risk stratification for further cardiac events, a submaximal exercise can be done after 3 to 5 days and symptom limited exercise test can be done after 5 days also. That is our other protocols are there for treadmill test except bruise. There is modified bruise protocol can be done. Dynamic 1 and Swiss 2 trial told us that beneficial effect of PTCA performed late after MI in patients with persistent ischemia on stress testing does help. Inspire trial did told us that adenosine systemic SPECT was effective for monitoring post-infarct ischemia. So stress testing with imaging is a viable mean of identifying high-risk patients like patients with severe ischemia, left main disease or triple vessel disease who could still benefit from late reperfusion therapies. Further risk stratification can also be done with helium scan, technetium 99 SPECT, FDG, cardiac MRI. That is also told us by multiple trials. And revascularization should be considered if viability is demonstrated. So let's come back to our patient. Here delayed presentation, there was ongoing chest discomfort, ECG did show changes, echo did show preserved thickness. But what should be the next step? Stress testing cannot be done. Treadmill test cannot be done as patient was having ongoing ischemia or ongoing chest pain was there intermittently. So this patient was not subjected to treadmill test. Other option would have been helium scan, FDG PET scan, low vitamin stress echo, contrast enhanced MRI. But as echo did show us preserved thickness, so we go ahead with low vitamin stress echo. Low vitamin stress echo showed biphasic response as expected. So what should we do now? Rush to cath lab, manage medically, or investigate further? See, we have all reasons to go ahead with cath lab because there was preserved thickness, there was pain, BP was borderline, so there was already all.
But do we really need to do this? You know what I mean? Because
No.
if the patient has says I have ongoing ischemia,
Patient has ongoing ischemia,
so there is no question of doing a
low
dobutamine or PET or CT or MRI, nothing.
ongoing pain, but it was not continuous pain, so vitamin was done, and it did show biphasic response.
But this subject is special to vitamin stress echo. Really?
Yes.
BTVF
There is risk of VTVF. EF would have been less than 30%, we would not have done dobutamine echo.
But he is having ongoing pain. How will you subject him?
Then it can be done. So
Sure.
we have to show something that this myocardium is still viable.
Why we take a risk on it and then catch up?
The catcher was ready on standby.
Then
No,
why you
but,
should not ask to catch up directly? Yeah? Ongoing is
This was for lecture purpose.
No, it is controversial. Yeah.
It is controversial.
Yeah, જે તમે બોલો છો એ અહીંયા discussion કરવા પૂરતું ઠીક છે, but your students are also sitting here. You need to be careful.
But actually this patient was subjected to
You are subjected
on
to
OPD basis. It was report was for dobutamine.
But isn't it contraindicated if there is a chest pain ongoing?
It was not ongoing, it was intermittent chest pain. So patient was also not very willing.
So if you write ongoing, that means in a vicinity of some minutes or hours he is complaining about pain.
Yeah.
Probably
so
it is
some
that
pain every day, but not continuously. Not
So according to me it is contraindicated. But you have to
yes,
discuss.
it is doubtful. It is
No,
doubtful.
not about doubtful. આજે મને પેન થયો હોય ને બપોરે હું તારી ઓપીડી માં આવું તો મને ડોપિટામિન સ્ટ્રેસ માં મૂકી દે તો પ્રભુ.
But many times patient has a report. We have to dobutamine and many times patient had developed MI on dobutamine.
Of course, but
At least I know 4 or 5 patients I know.
see, we know the limitation of dopamine stress, but a patient who is complaining of pain, how you can subject?
Sorry, ECG changes are means baseline. With pain, ECG is normal. There is no sign of ischemia on ECG.
Then yes, then it has to
But our patient
But
got to
this patient, it was
how this patient can be subjected?
એટલે માં કાઢવાનું તો કે કાઢ આમ કે
not
તો 4,500 રૂપિયા અકેલ ખાધું.
માં કાઢવાનું હોય તો નામદાર થઈ જશે
Margaret direct.
ચાલો આગળ, ચાલો.
So patient was subjected to angiography.
મુક્તાથી.
The LAD was
Not totally.
not totally. There was some trickle of
એમનો આ ડોપિટામિન સ્ટ્રેસ ઇકોના વિડિયો છે આપણી પાસે ને ECG?
ના એ unfortunately નહીં મળ્યા મને. So there was some trickle of flow going down the LAD. Maybe that's why intermittently he was asymptomatic. So this patient was subjected to balloon dilatation followed by angioplasty. This was the final result. So what we should do after end of this lecture? Unstable patient. Ongoing symptoms, unstable hemodynamics, electrical instability, revascularized, whatever may be the day 2, day 3, day 7, whatever. Stable patient presenting less than 72 hours. Mild or no symptoms, or stable hemodynamics. Significant lesion in infarct-related artery needs to be revascularized. Occluded infarct-related artery needs to be revascularized based on open artery hypothesis. So CAG should be done with intent to revascularize up to 72 hours. Beyond 72 hours, the major problem is always here. Ideally, a stress or viability testing needs to be done. If there is positive test, CAG with intention to revascularize. So this is what came from all guidelines and all.
તો 2014-15 સુધી જ આવ્યું ને આપણે તો હજી 10 વર્ષ બાકી.
2018 સુધી, 2018.
તો હમણાં
Was
આપણે
last
કઈથી
year.
આવ્યું?
Question?
Same.
એવું?
After that guidelines is